Extracorporeal cardiopulmonary resuscitation, or ECPR, is a time-sensitive rescue strategy for carefully selected patients in refractory cardiac arrest. During ECPR, extracorporeal membrane oxygenation, commonly called ECMO, is initiated while resuscitation continues. The system temporarily circulates and oxygenates the patient's blood, creating time to identify and treat a potentially reversible cause of cardiac arrest. ECPR is not appropriate for every patient. The pre-hospital team's responsibility is to recognize a potential candidate early, deliver accident resuscitation care, and initiate a pulsar activation, and coordinate transport with the receiving ECPR center. Let's have a chat with Dr. Eden from Oshner LSU about why ECPR is important to Shreveport Fire Department and all of the citizens within Shreveport.
The why for why we're doing this is to improve outcomes from out-of-hospital cardiac arrest. As you very well may know, the outcomes for out-of-hospital cardiac arrest survival rate is well less than 10%, and those that go home neurologically intact are even less than that. So our goal here is to improve that survival. As far as what the data have shown, there have been multiple trials looking at this, both in the United States as well as worldwide, that have shown mortality benefits to the point of somewhere around 30 to 40% survival in systems that are well done. The most probably significant of these was in Minneapolis, Minnesota, where they actually stopped the trial early because the outcomes were so good in terms of survival using ECPR. And ECPR, which is essentially it's VA ECMO, but it's essentially cardiopulmonary bypass and putting the patient on in a very rapid manner, so that then we can have the time to figure out what is wrong, what caused their cardiac arrest, while perfusing their organs, including the brain, which is most commonly the issue, or the organ that prevents a good survival with a good neurologic outcome.
Now let's talk about some patients that may be unlikely to benefit. Findings that may make ECPR inappropriate include an unwitnessed arrest, prolonged absence of CPR, an irreversible or clearly non-cardiac cause, devastating trauma, uncontrolled hemorrhage, terminal disease, or a valid do not resuscitate order. Advanced age by itself should not be the only consideration. The entire clinical picture, including arrest circumstances, baseline function, rhythm, your response to the treatment, and estimated transport time must all be considered and communicated to the receiving team. Do not delay standard resuscitation while determining eligibility. ECPR consideration should begin very early, not after every conventional option has been exhausted on scene. When a patient has persistent ventricular fibrillation or pulseless ventricular tachycardia, despite high-quality CPR, appropriate defibrillation, vascular access, and ACLS medications, the team should begin evaluating the patient for a regional ECPR pathway. This usually should transpire within the first 5 to 10 minutes. Assign one team member to manage the activation while the remaining crew continues uninterrupted resuscitation. Think ECPR early during refractory VFib or VTAC. Now that we discussed the candidates for ECPR, let's talk about where we can take these patients in Shreveport.
So for the citywide ECPR program that's starting in July, there's 2 hospitals that will be involved in this program. Those 2 hospitals are Oshner LSU, Shreveport, and Willis-Knighton North. And the reason that those 2 hospitals are the ones that are going to be involved in this is they have the equipment and the personnel that are set up 24/7, 365 to be able to provide this service in a rapid nature. The goal will be to get these patients to the ECPR center as quickly as possible, ideally less than 20 to 25 minutes from the time of arrest, certainly less than 30, so that the teams at these 2 centers will have the opportunity to be able to get these patients on ECPR in the requisite time. The goal from time of cardiac arrest to the time that we have the patient on pump is 60 minutes. And the data has shown that the shorter that time period is, the better the chances of a good outcome. So for that to happen, this is a huge partnership with Shreveport Fire in getting these patients to us so that we can have a potential good impact on survivability.
The two local hospitals identified for potential eCPR activation are, as mentioned, Ochsner LSU Health Shreveport and Willis Knighton North. In order to select the appropriate receiving facility, we need to make sure that we are the closest facility, and you can utilize BioTel or 911 services for that. Afterwards, we'll be using Pulsera according to our current Shreveport Fire Department destination guideline, patient circumstances, transport time, hospital availability, and direction from medical control or the receiving eCPR team. An activation does not automatically guarantee that they will continue eCPR, but it does alert the receiving hospital to evaluate the information, confirm team and resource availability, and provide destination guidance. Activate early, confirm acceptance through Pulsera, and always follow the destination guidance. As I mentioned, we'll be using Pulsera for our eCPR activations. Let's talk to Dr. Eaton over at Oshner again about how this is going to help us make sure that we notify the teams and get all the information ready.
So for the citywide eCPR program starting this July, we are going to be using Pulsera to activate this program at both institutions that are participating in this. The very brief basic criteria that we are going to use for these patients are witnessed out of hospital cardiac arrest, initial rhythm of VF or pulseless VT, immediate bystander CPR or EMS witness arrest, no sustained ROSC after 10 minutes of high quality ACLS, and an estimated transport time to one of the two eCPR centers of less than 20 to 30 minutes. And as best as you can tell at the scene, given limited information, no major comorbid illness that limits survival. These are going to be activated, as said, via Pulsera. So you will activate them from the field, which will immediately notify one of the two centers that you are bringing a potential patient for eCPR to the center. This will give us the time that we need to get our equipment completely into place so that when you arrive, we can quickly go through again what the information is that you have, gather any additional information that we can in a very rapid period of time, and make a very quick decision, ideally less than 5 minutes from arrival of EMS with the patient, on whether we are going to proceed with eCPR or whether it's not indicated in a particular case. These patients will all be on a Lucas device, and we will be doing our best to get these patients cannulated and on pump as quickly as possible. And the Pulsera activation from the field will make that process possible because it will give us plenty of time in advance notice that we can be in place and ready to go as soon as you arrive.
So now we know that we're going to be using Pulsera. What do we need to actually put in Pulsera in order to maximize our time and maximize transport time?
Only things that need to be put into Pulsera are patients' age. Again, sometimes you don't know exact numbers. Guesstimate is as good as you can. Patient's age, any known medical history that you do have, and that's about it. You know, we just need the really basic information so that we can activate and move forward. You're already going to have the basics met that we've provided, that are, you know, very basic criteria. You know, we will go through a quote unquote more detailed evaluation once the patient arrives at one of the centers, though that will be a very rapid a couple of minutes that we take to do that evaluation.
One of the really neat things about Pulsera is that it can replace your radio report. So in order to make sure that we maximize our time, we need to send the Pulsera alert as soon as the patient appears to meet eCPR criteria, then provide a concise verbal or text update using a structured format. For example, a paramedic radio or phone report would be Oshner LSU, Willis Knighton North. This is Shreveport Medic 5 with a potential eCPR candidate. We have an approximately 52-year-old patient with a witnessed cardiac arrest. Bystander CPR had begun immediately. The initial and current rhythm is ventricular fibrillation. Patients receive 4 defibrillations, 1 round of epi, amiodarone, and no sustained ROSC. Mechanical CPR is in progress, airway secured, and our estimated arrival time is 12 minutes. Please confirm eCPR acceptance and destination. Once you've put that in, we need to update Pulsera immediately after any major changes, including return of spontaneous circulation, rhythm conversions, recurrent arrest, changes in airway status, or significant deterioration, or revised arrival time. By making sure that you put that radio report into the Pulsera, that is then communicated to the emergency department as well as the Pulsera team so that they are in hand with you with the resuscitation. Transport must not compromise resuscitation quality. Before moving the patient, confirm effective compressions, secure the airway and vascular access, attach the defibrillation pads if they already haven't been done, and secure all equipment, assigning clear roles before you move. Using mechanical CPR during movement and transport is essential when it can be applied without causing any prolonged interruption in compressions. Continue rhythm analysis, defibrillation, medications, ventilations, and any additional ACLS as you move to the ambulance. It's very important that we spend not much time on scene because the more time that we spend away from the hospital, the smaller the window becomes to be able to provide ECMO CPR. Again, to remind us, we need to minimize chest compressions that are manual, and we need to maximize our mechanical CPR, defibrillate promptly, avoid hyperventilation, monitor your end-tidal CO2, secure all devices, and continue Pulsar updates as necessary. On arrival, provide a rapid handoff that includes the collapse time, CPR start time, initial and any subsequent rhythms, total defibrillatory shocks, any medications administered, your airway interventions, end-tidal CO2 trend, episodes of ROSC if any, suspected causes, and changes during transport. Continue CPR and assign resuscitation tacks until the receiving team explicitly assumes care. For example, a handoff would be a witness arrest at 14:05, bystander CPR began at 14:06, initial rhythm was VFib, 6 shocks were delivered, the patient received 4 doses of epi and 300 milligrams of amiodarone, no sustained ROSC occurred, mechanical CPRs remained in place with end tidal ranging from 22 to 28, and the last rhythm check remained VFib despite defibrillation. Wow. After talking with Dr. Eaton and Dr. Trosclair from Willis-Knighton, we've really come a long way for Shreveport. And ECMO is just the tip of the spear. Successful eCPR or ECMO begins before the patient even reaches the hospital. It really depends on us in the pre-hospital setting to recognize potential candidates early, maintain high-quality resuscitation, and activate the receiving center through Pulsera early, pretty much while you're still on scene. Communicate complete and accurate information, and then confirm acceptance and transport it to that directed eCPR-capable hospital. Early recognition and coordinated action may provide a carefully selected cardiac arrest patient with not only an opportunity for survival that conventional resuscitation alone cannot provide, but also a chance to prolong their life and continue on as if nothing happened. We need to make sure that we identify early and activate early, making sure that we continue excellent CPR with our compression devices, the Lucases. We need to follow our current Shreveport Fire Department protocols and inform our online medical direction if there's ever any changes. If you have any questions, please reach out to the EMS office or administration. And as always, thank you for helping our citizens.